In the last podcast we looked at A for A with C spine control. And remember, this is all part of the primary survey, which is A, B, C, D and E. So A was A with C spine protection, and we've done that. The next one we're going to look at is breathing, B for breathing. And here we consider breathing and ventilation. So with a casualty, you should expose the chest to make sure you're getting normal movements of the chest wall. Because if there's normal movements of the chest wall, this indicates that the air is going in and out of the lungs. This is what we call ventilation. So we're observing for normal chest movements, and these should be bilateral. They should be the same on both sides. Bilateral means the same on both sides. Normal chest movements. And at the same time, you can look at the chest wall to see if there's any injuries, or feel the chest wall to see if there's any injuries. And then we should also listen to the chest using a stethoscope to make sure we can hear the air going in and out of the airways. In the chest there's a bronchial tree. The bronchial passages are the airways, carrying the air down to the small air sacs, which are the alveoli. So the air needs to be going in and out of the bronchial passages to facilitate normal breathing. And we can listen for that with a stethoscope to hear the air going in and out. And at this time we want to identify any significant chest injuries. Now, all injured patients should be given oxygen at high concentrations if that is available. So in the hospital situation, for an injured patient, we'll give them high concentrations of oxygen. And if a patient's not breathing for themselves, we can breathe for them. This is called intermittent positive pressure ventilation. We inflate the patient's lungs using positive pressure. We can blow into the patient's lungs using mouth-to-mouth ventilation, or in hospital situations, we can use a bag, a valve and a mask. So we can fit a mask over the patient's nose and mouth and blow air, preferably oxygenated air, directly into the patient's lungs. At the same time as this, we can monitor the amount of oxygen in the patient's blood using an instrument called a pulse oximeter. So that's A, B. Next it's C, and C stands for circulation and hemorrhage control. Now, if a patient's lost a lot of blood, their blood pressure will start to drop. And to compensate for this, the heart will beat faster. There will be a tachycardia. Tachy means fast. The heart rate will increase. And the pulse will become faster, weaker and threadier. So we can feel the patient's pulse and see if it's fast, weak and thready. And this will indicate that the patient has probably lost some blood. As well as that, we can look at the colour of the patient. Do they look grey or do they look white? And do they have cold hands and feet? Because again, if someone's bleeding and the blood pressure starts to drop, the nervous system will constrict, will close down the peripheral blood vessels, the small blood vessels near the surface of the body. This will save blood for the vital organs like the heart, the lungs and the brain, but it will make the skin look a white, pale colour. So pulses will be fast, skin will be a greyish, whitish, cold colour, and the patient's level of consciousness might be reduced. They might be a bit groggy. And what's very common when someone starts to lose blood is they become anxious. So the patient might be anxious and agitated. All these things can indicate that the patient is bleeding from somewhere. The bleeding could be external onto the floor, or it could be into one of the body cavities. So for example, the patient could be bleeding into their chest, they could be bleeding into their abdomen, they could be bleeding into their pelvis from a broken pelvis, or they could be losing blood from the long bones, from long bone fractures. Because remember, if you break a femur, you can lose over a litre of blood from a broken femur. If you break a tibia, that's your shin bone, you can lose 750 mils of blood from that. If you break a humerus, which is the upper arm bone, you can lose 750 mils of blood from that. So it doesn't take many broken bones before there is a significant amount of blood loss. Now, if someone's bleeding, if at all possible, of course, we want to stop the bleeding. We want to establish definitive control of the hemorrhage. So stop the bleeding if we can. Then we want to replace the fluids which have been lost. So what we do is give crystalloid type fluids into a vein, intravenously. So we want to give fluids like normal saline or dextrosaline or Hartmann solution directly into a vein. And we want to give the patients more fluid back than they have lost. If a patient loses a litre of blood, we want to give back 3 litres of fluid. We want to give 3 mils of intravenous fluid for every mil of blood that the patient has lost. And we want to keep monitoring the condition of the patient to make sure that they are responding to the fluids that we're giving as we would want them to respond. So that's A with C-spine control, B with ventilation, and C with hemorrhage control. The next one we want to look at is D for disability. And here we are examining the neurological status and level of consciousness of the patient. So we want to establish the patient's level of consciousness. Are they fully conscious, or is their level of consciousness reduced? And we do this using a scale called the Glasgow Coma Scale. So we want to see what Glasgow Coma Scale, or GCS number, that they have. And the big advantage of using Glasgow Coma Scale is we can get a number, and then we can see if that number is getting worse. We can establish trends if we've got a number. Then we want to assess the size and reaction of the patient's pupils, and we want to see if they're weak on one side or the other. They're called lateralizing signs because they could indicate some problem with the brain, for example, pressure on the brain from a blood clot. A blood clot within the skull would be a hematoma. And we want to assess if there's any spinal cord injury or potential spinal cord injury to the patient as well. E stands for exposure. So we need to fully expose the patient. Usually we'll cut off their clothes to stop damaging any injuries or to stop making any injuries worse. At the same time, of course, we want to make sure the patient doesn't get too cold. We want to prevent hypothermia. But basically what we're looking at now is for any other injuries. So it's often a good idea to start at the head and work the way down to the patient's toes, looking for other significant injuries. So A, B, C, D and E. Airway, breathing, circulation, disability and exposure. That is the primary survey. A, B, C, D and E. B, C, D and E.